Hi, good evening, everybody. So it's the eve of Merdeka, which is actually the Independence Day of Malaysia. If you're not from Malaysia, it's a day that we celebrate to commemorate, and it's been 66 years since we have gained independence from the British government, the Great Britain. And we have, of course, Dr. Pei, who is my colleague in Sunway, giving us a talk, which is kind of a continuation from the previous talk that he gave us. And it turned out to generate a lot of interest, actually. So we are going to continue with diabetic retinopathy. And without further ado, come Pei, come, let's start, because I need to go back partying.
Okay. Hi everyone. So welcome to this literally this once in a blue moon event. Because apparently today is a blue moon.
Is it?
Yep. It's the first blue moon in 3 or 4 years.
Oh, really? Yeah. Okay, after that, I'll have
Yes.
to look.
So the next one will be in 2027 apparently.
Oh.
So this is literally a once in a blue moon event. So
Oh,
welcome everyone. So as Dr. Betty mentioned, this actually formed the second half of the talk that I had given initially in March about blur vision. And at that point, we had talked about, how to assess vision, the different tests that are involved, and the nature of blurring, asking about the duration and effect on visual acuities. And then we moved on to how we approach it, going from the front of the eye to the back. So today we're kind of talking about number 5 here, which is retina issues, more related, so we had talked about accommodation issues, problems with the cornea, the lens, and then into the vitreous. And now, there's some retinal pathology involved as well. But the specific mention needs to go up to diabetes. It's contrary to popular belief. We all think that cataract or glaucoma is the commonest cause of blindness. But in actual fact, diabetes is the commonest cause of blindness in working age adults. I think this has been, in the last 3 weeks, it has been highlighted even more because I've had 3 patients below the age of 50 walking into the clinic with counting fingers level of vision in both eyes. And so this really highlights, the importance of awareness that actually it is diabetes that is the commonest cause of blindness in working age adults. And a statistic that a lot of us don't realize is 1 in 5 Malaysians are diabetic, but only 36%, according to a survey, attribute this to blindness. Whereas in fact, as I mentioned, it is the commonest cause. So if you think, actually retinal disease affects 1 in 3 diabetics. So you can do the sums, and out of those 1 in 3 diabetics that develop retinal problems, a further 1 in 3 of that subset will develop vision-threatening eye disease. So doing the sums, it's worked out to about 500,000 diabetics in Malaysia with vision-threatening eye disease. So I've seen 3 in the last 3 weeks and have operated 2 of them already. So why does it happen? Okay, so broadly speaking, when we look at the retina, which is the camera film of the eye, we look at 2 parts. One, the overall retina, where we grade the diabetic retinopathy, or DR for short. And that has been established since the 1980s, a grading system where it's broadly divided into non-proliferative and proliferative disease. The difference is, with proliferative disease, there's a growth of abnormal new blood vessels from the retina. So it grows from the surface like sea fan, like sea fan corals. So that's diabetic retinopathy. It is a, if you like, it is a secondary hallmark of ischemia, the level of ischemia in the retina. So it's a reflection of the poor blood supply in the retina overall.
Are these
And
due to collaterals?
no, it's actually de novo new blood vessels
I see.
that are formed because the ischemia drives a chemical called VEGF, vascular endothelial growth factor, which causes the endothelial cells of the existing vessels to proliferate and try and grow blood vessels which are immature. So it's a misdirected healing process, if you like.
Oh, because when we have blockages in our coronary arteries, we have collaterals forming, which are like new vessels, but it is also due to ischemia and a blockage. So it must be the same factor that is
Kind of the
driving
same.
it.
So that the ischemia, the collaterals and all, they form actually in the non-proliferative phase.
I see.
So it's a precursor. So in fact, we'll talk about this at the severe stage, right? There is this formation of these things called intraretinal microvascular abnormality. So these are very fine collaterals that open up. So for example, if you block a river mouth, the river behind, the water pressure behind finds collaterals or little tributaries. So these are seen as these ermas. And then later on, as the process deepens, the ischemia deepens, that's when you get abnormal de novo blood vessels forming. So that's the retinopathy, the global retina. But the other thing that's most important is this little center 500 micron area called the macula. So that is affected in the sense that and it's affected in a condition called diabetic maculopathy. So it's either absent or present, involving the center or not. So let's talk about diabetic maculopathy. So here we have a diabetic retina. If we ignore all the little blood hemorrhages that you can see, is my cursor visible?
Yes.
Okay, so all these blood hemorrhages, so this would be in the peripheral retina. Okay, so let's concentrate on this center area here, which is the macula. And you can see these white spots and you can see these little tiny dots. So these are called microaneurysms. And so this is weakening of the capillaries, and it's like a garden hose where the wall is weak, so it forms a little bubble. And these things leak, and they leak fluid, and they leak just like as the water, as the tide comes into the shore, it leaves behind debris at the edge. So as it leaks, all the cholesterol, lipids are deposited at the edge of the leakage. So you could say, if you look at this picture here, all the little microaneurysms, this is the area that's leaking. So in a almost like a circular fashion, or we call it a circinate pattern, it leaves hard exudates at the edges of leakage. And this is threatening the center here. So if we assume that the optic disc is 1.2 millimeters, so you're looking at less than a millimeter away. And so this is called macular edema, edema of the macula. And these days, right, we can look at this, but we cannot tell if this macula is thickened or not, because in 2 dimensions, we cannot discern, is there fluid at the retina or fluid in the macula or not. So these days, we rely on this machine called the OCT. And this gives you a really amazing photograph these days. You can see in profile, you can see the 9 layers of the neurosensory retina. And this part here, the dip, corresponds to this dark area in the center called the avascular zone. Now, this dip is present because at this point in time, all the photoreceptors are compacted and right in the center here, and all the nerve fibers are pushed to the side of the neurosensory retina. So this scan will give us a cross-section where you can pinpoint an area here, And in cross-section, you can see that it's actually swollen. So you can appreciate that on cross-section, the macula is actually thickened. So, I mean, we are talking about micrometers here. So, this could be about 300 microns or 400 microns, and a normal macula would be about 250 microns. So can you imagine the human eye's resolution in 2 dimension cannot discern the difference between 250 microns and 400 microns. So the OCT scan has become almost sort of compulsory, I would say, if you want to properly examine macula. So you can see almost the pathology involved here. There are these cystic spaces which correspond to fluid at the center of the retina. So this is center involving diabetic maculopathy. And you can take measurements. So this one, as I mentioned, 359 microns. It gets a bit thicker out towards the side here. And if you can even do OCT angiography these days. So using this machine, you can generate a map of the capillaries, and it shows area where there is leakage, where there's an enlargement of the capillary zone. And these are sort of secondary markers as to show ischemia as well at the macula. So, in the past, we used to laser these, with a laser. So essentially you put a contact lens on and you use the laser energy to, I wouldn't say it's thermal energy, but I think what you're really doing is tickling the cells beneath the neurosensory retina to try and absorb the fluid. So up until about the early 2000s, that's all we had. But it reduces the risk of moderate vision loss by 50% over a period of 3 years. But the problem with laser is that it's very difficult to titrate, and very often when you apply the laser, there's no reaction. So there's no feedback. So you don't see any reaction. So the temptation, especially if you're a junior, is to try and up the thermal energy to get the idea is you get these light reactions, light gray reactions. But the problem is there's this phenomenon. So this is an early laser that was done. And this is what happens later on. You get scar tissue. And these scar tissues, they enlarge over time. And you get this phenomenon called laser creep. So the patient could well be dry. The macula could be dry and their vision is restored. And a few years later, they pitch up with central vision loss that is irreversible because the laser scars have expanded to involve the center part of the vision. And you can see that in this scan of a patient that was lasered at a different center. They pitched up with this very thin atrophic retina with loss of photoreceptors at this layer here on the OCT scan.
Pei, can you switch on your camera, please?
Oh, sorry.
Yeah. Okay.
Yeah, is that?
That's fine.
Okay, sorry about that. So yeah, so this patient has an atrophic macula now and has lost vision. And what started off as an intention to treat has now, I hate to use the B word, it's blinded the patient. So this patient has lost their central vision. So they cannot see faces, they cannot read, although they have peripheral vision around. But if they were to look directly and the image falls on this area, they would have a black spot.
So what? Okay, go on. Yeah, go on.
These days, we have done different types. We have a scanning laser that automatically applies. And you can imagine in the past, right, when you are lasering a spot within 500 micrometers of the center, it's nerve-wracking. I try not to drink coffee on that morning, because just a little bit, like say if I was aiming here and I move here, and I accidentally applied the laser at the center, then you know this patient is going to have loss of central vision. So it's a very difficult thing to do, you know, and yeah, so those were the bad old days, if you like. There are new versions of lasers which are lighter, and there are talks of sub-threshold energy treatments, so you're not applying a direct thermal energy. And you know, there are arguably cost reasons behind, because laser is much cheaper than the alternative. So this is where viewer discretion always comes in. So these days, a lot of times we do intravitreal anti-VEGF injections. So as alluded to, as I mentioned earlier, you know, you can have regulation of a compound called vascular endothelial growth factor in the presence of ischemia. And vascular endothelial growth factor also influences capillary permeability, leakage of retina. So these days, most of us tend to do an intravitreal injection, meaning we inject the drug directly into the cavity of the eye, into the vitreous, where the drug can affect the macula directly. And it sounds horrible, but over the last 20 years, you can see all the newer drugs, bevacizumab, ranibizumab, aflibercept, brolucizumab, faricimab, you know, all these are recombinant antibodies. And then on top of that, you have steroids as well, which affect vascular permeability as well. Sounds terrible, but actually it works very well. This is a patient that had an injection at 0 at start month 1, month 2, month 3. And you can see a resolution of you can see a resolution of the thickening, you know, with time. And I don't know if I can play the video. Yeah. So this is a live video of a patient having an injection, you know, and you can see this is done entirely under local anesthesia.
You're right. With discretion.
Yes. So done under local. And that's it. And, you know, for the purpose of filming, I'm going really slow. Normally, I would have just done in. Usually, I tell the patients, okay, a little bit of a scratch, 5 seconds, 5, 4. By the time I count down to 1, I've withdrawn the needle. So that's it, 5 seconds of injections. But it is repeated on quite frequently, depending on the drug. So most patients, I tell them they will need about 6 to 8 treatments in the first year, 4 to 6 in the second and third. If they can maintain a dry macula for a period of at least 3 years, it's said that buys about 5 years worth of protection, and it can be repeated, you know.
When you say dry, means it's not edematous, is it?
Correct. So that means the capillaries are not leaking.
Oh, I see. Okay.
Yeah, because the longer the leakage is present, there is death of the photoreceptors, and with death of photoreceptors, there's loss of function. So the whole point of this treatment is to prevent loss of vision. So as with a lot of things, and we'll talk about this later on, screening is very important. So that's diabetic maculopathy. And now, so we move from the center and we look at the rest of the retina. So this is the same retina as shown before. So now if we focus beyond the maculopathy, the heart exudates and microaneurysms, you can see here that all these blood hemorrhages, very deep blotchy hemorrhages on top of the microaneurysms. And if you look at this disc here, there's this fine little blood vessels on the surface of the disc. So these are new blood vessels growing at the optic nerve. So what's actually happening is that there's widespread ischemia, and that's reflected in these blotchy hemorrhages. So if you do a angiography, you can see these areas, these black areas are just not getting any blood supply. These are the normal retinal vessels and the background. So there are widespread areas of ischemia. And so there's upregulation of all all these chemicals, and you get a pattern. So if you develop 4 quadrants of these blood hemorrhages, 2 quadrants of these venous bleeding, because if you look at the veins here, it's not a straight lumen, it's not an even lumen, it's almost sausage segmented. Yeah, so venous bleeding, 4, 2, and 1 quadrant of IRMA, the intraretinal microvascular abnormalities that I was talking about, which arguably you can see here. So, so almost like tributaries that develop between the veins and the arteries, So if you see this 4, 2, 1, that means this patient has severe non-proliferative diabetic retinopathy. But in the presence of the growth of new vessels, this patient has now moved on, is graded as proliferative diabetic retinopathy. So if the new vessels develop as the disc, they call NVDs. And if they develop elsewhere, they call NVEs. Ophthalmologists are simple people. No fancy names. Yeah. So the reason this is
elsewhere.
Yeah,
New
it
vessel
really is
elsewhere.
correct. Yeah, center involving diabetic maculopathy. It just does what it says on the box. So the reason this is important is because in the presence of new vessels, right, they run the high risk of bleeding. So these new vessels are extremely fragile and they grow. So if you like, if this is the vitreous is in the cavity of the eye, it's like a jelly, it's like a net. These abnormal new vessels are growing into the vitreous, which acts as a scaffolding. So the vessels are hanging on to the vessels, and as the vitreous floats around, as we see floaters, the blood vessels can rupture. And as it ruptures, all the red blood cells are released into the vitreous and trapped in the vitreous. And if they're trapped in front of the macula, then you're going to have quite profound or severe vision loss. And later on, if you leave these alone, if these are not addressed, what will happen is that the new vessels will shrink and they will form scar tissue, as in this bottom here. And that scar tissue will shrink. And because the vitreous is holding the vessels up, as it shrinks, it pulls the retina off. So then you get a tractional retinal detachment. So that's what I was talking about. So we grade them as non-proliferative, mild, moderate. When they get to the severe stage, if there are 4 quadrants of blood hemorrhages, 2 quadrants of venous bleeding, and 1 quadrant of IRMAs, you know this patient is at high risk. 90% of these patients will bleed within 5 years, 90. So it's almost certainty. So now, how do we treat this? So with severe non-proliferative, and some would argue even this patient in the background here, where there are new vessels but no vitreous hemorrhage, you could laser them. So this is an example, a picture of a patient with the old type of thermal scatter laser. So what laser is doing is essentially you're burning this retina. If you count the spaces that they burned off, you've burnt off about 50% of the retina.
Yes.
So the idea is that when you burn the sick retina, right, you preserve the limited blood supply for a limited amount of seeing retina. So in other words, you're trying to redress the oxygen supply and demand. And laser is very effective, no doubt, 90%. So as I mentioned, 90% risk of severe vision loss if you have a severe non-proliferative diabetic retinopathy or early proliferative diabetic retinopathy. With laser, you can reduce this risk from 90% to less than 30%.
Oh.
So the newer lasers are much more gentle. You can see, they're more spread out. There's less scar tissue. There's more retinal sparing, if you like. So this previous type of laser had a high risk of narrowing the patient's visual field. So now you can imagine if this was a patient below the age of 50 who needed to drive a bus, for example, that would have catastrophic effect on their ability to work. And it could explain the driving standards in Malaysia as well. So these days, we tend to do much gentler laser and try and spare as much of the peripheral retina as possible. But again, our new best friend, our new BFF, is the anti-VEGF injections. So a lot of times these days, we can combine the two of them. So we do serial laser and anti-VEGF injections. Anti-VEGF injections work very quickly. So for example, in the earlier photo where a patient had new vessels, if you did an injection, these new vessels would shrink within 1 week. If you examine them the following week, the new vessels may have shrunk. So sometimes in patients with early proliferative diabetic retinopathy, you can start by injections and then followed by laser, or combine them together, because the beneficial effects of laser take time. But sometimes in patients with early proliferative diabetic retinopathy, you may not have the time. In the past, we used to start lasering and patients would still bleed. And they bleed because the disease is progressing. So I always tell patients, it's like a race. The damage caused has raced this far ahead, and we're only just now starting to try and catch up with the disease. In the past, doing laser, you have an incremental effect over time. So you have to do about 4 sessions over a period of 4 to 6 months. So by combining VEGF injections with laser, you can take bigger steps forward and hopefully catch up faster with the disease to prevent progression to, yeah.
Oh, so you actually do combination therapy in that sense?
Yes.
And
Correct.
this anti-VEGF,
VEGF, yeah.
it's actually to reduce the new blood formation, right?
Correct. The new vessel formation, to shrink the new vessels.
Or
And
to
then
shrink also the new vessels. Okay.
correct. So there's almost like a two-pronged approach. You're using chemicals or drugs to shrink the blood vessels. And then you're also addressing the root cause of the problem, which is the excessive amount of ischemic retina.
Okay, just now you were saying that by using the laser, we can reduce the risk of blindness, the incidence of blindness from 90% to 30%.
Under 30%.
Yes. So what if we use combination therapy with this anti-VEGF?
Yeah, I'm afraid I don't have that data. This is something that I think, instinctively, many of us have been doing over the last few years. So I do believe there is a trial out there to show the efficacy of it. But I do believe in it strongly enough that I offer combination treatment to all my patients.
You've shown us many of these anti-VEGF in the market. Do you have a preference, and why?
So let me forward to the next slide. So VEGFs have been around now for about 2 decades, so it evolved from this where we were lasering. Yes, yeah. So since 2002, but for various reasons. But for diabetes, really, it's only been used or officially used FDA approval. Ranibizumab was officially approved for diabetes and diabetic macular edema around about 2010. And for diabetic retinopathy for 2014, 2015. So you can use pure VEGF, so just injections to try and control the diabetic retinopathy. but it really only, the data is available for patients with severe NPDR, so severe non-proliferative changes. So if you like what I'm talking about, where you're doing combination, it's a little bit off-label. It's a
I
bit
see.
off-label. Although it's accepted, there is a significant body of evidence to accept that it works. So it's only been in the last, so there's a variety on the market. It's which one I prefer depends in some ways on the patient. So Avastin was the first one. Avastin was a drug that was used in breast cancer and was found to improve vision in some patients. And so they started injecting Avastin, but the company decided to reformulate the drug and use the reformulation called Lucentis to go forward with FDA approval. So the FDA approved drug, the licensed drug is Ranibizumab or Eccentrix in Malaysia. It's been around long enough now. You get generic versions of it, and then the newer generation, if you like, is this Aflibercept that not only targets VEGF but targets other factors, other neural factors like interleukins and platelet-derived growth factor. And it's thought that Eylea buys you a longer duration of action between injections. So cost no barrier at the moment, if cost is no barrier, because this drug is expensive. Each drug, 0.05 milliliters of drug per eye is about 2,300 ringgit just for the drug alone. So in a patient with chronic condition where you're doing 6 to 8 injections per year, the costs really build up, especially if you're treating 2 eyes. Now, by comparison, Ranibizumab is half price at about 1,003, and Bevacizumab, Avastin, the original one, is about 400 ringgit.
So
But
one
this
ball
is
can only treat one eye?
correct. So Ranibizumab and Eylea, it's one bottle per eye. Although there are practitioners who do divide the bottles, we are not allowed to do that in some way. So if we are treating 2 eyes, it's 4,600 ringgit worth of drug.
But Chinese got such small eyes.
It's not the 0.05
Chinese
mils,
got small eyes. We should be able to use one valve for 2 eyes in Chinese. Okay, go on, go on.
On an off topic, that's size isn't all that matters. So
say the man.
0.05 milliliters is enough. So my to answer your question, yes, this would be my drug of choice, but I have to ask the patients about affordability and, can you come back? So the newer drugs are all about extending the duration in between treatment. But a lot of the newer drugs are not in the Malaysian market as yet, although Vivitsmo has just been launched recently. Yeah. And that's supposed to buy you a 3 to 4 month duration in between injections. So we move on to, so this is an example of a patient, so look at that pre-treatment right eye with blood hemorrhages, in all 4 quadrants. And in the left eye, it's actually bled. There's vitreous hemorrhage there, So you could argue the right eye is in the severe stage. The left eye is in the early proliferative stage. That's early. This patient's vision was only reduced by a little bit. And this is how it looks. You see, just 2 lasers and 4 injections. And you can see the reduction in the blood hemorrhages between the post-treatment. And it's quite obvious, isn't it?
Yes, very.
And then you can see a resolution of the blood vessels. So the vitreous hemorrhage has disappeared. And it's gone from this to sort of white, altered blood. And again, there's a reduction. clear reduction in the number of blood hemorrhages around the retina. So I can show you a series of about 20, 30 patients that I've done so on, So I firmly believe by a combination treatment, you achieve better results much faster. But of course, the takeaway point with all this would be worthless if the diabetes was not controlled. Because then you're dealing with a moving goalpost. The disease is constantly racing away. So no matter how many steps you take, you're never going to overtake the disease. So yeah, another option in patients with early or early proliferative diabetic retinopathy would be vitrectomy surgery. So viewer caution advice. So those of you who are squeamish, this is what we actually do in a vitrectomy. It's like an endoscopic operation, but on an eyeball. So the instruments are absolutely tiny, so 0.5 millimeters in diameter. So that thing is, so what you're doing here is you're removing the vitreous. So this is a patient with a retinal detachment, but it's just to show you what the vitreous looks like. So you can imagine someone with vitreous hemorrhage. And it's said that just by doing a vitrectomy, you increase oxygenation to the retina by about 10%. So if you combine that with laser and intravitreal injection, that would be what I call the nuclear option. So sometimes in patients, yeah.
Sorry, does it bleed into the retina like it bleeds into the vitreous?
It can, yes. Sometimes you can get subretinal bleeding, but not very often, not very often. So these days, I mean, like say, you see like this thing with these trocars, right? These are not, they do not need to be sutured. So you just pull the trocar out and the sclera will just close on its own. In the old days before that, this was when I started training, we were using a combination of instruments that was about twice as large. With the 20 gauge ones, you had to open up the conjunctiva and, you stick a blade in to create a massive wound to fit this 0.9 millimeter instrument in. And you have to suture up the wall and then suture up so these days you can just, poke and run,
And you use local anesthesia with the eye drop?
Yes, you can. In these cases, usually I would give them a local anesthetic block because you don't want the eyeball moving around. So you would inject around the eyeball. So through the eyelid around the eyeball to numb the extraocular muscles.
Do they need heavy sedation?
I tend not to give them sedation. I think talking to the patient and reassuring the patient is as good as sedation.
I see. Okay.
Yeah. The problem with sedation is I find the patients tend to nod off. And if they nod off and then they wake up with a start, especially the very elderly, they can get very confused and very agitated.
They're very restless sometimes. So they
Correct.
move a lot. Yeah.
Yeah, correct. Considering that we are, millimeters away from disaster, you really don't want any movement. So most of the time I would give them, all the time, I would give them either a local anesthetic blockage or give them a full general anesthesia. So patients have a choice. Yeah. So now if as in all, like some of these patients, okay, fundus obscuring vitreous hemorrhage. So these are patients that have bled so badly that you just don't see the retina. So the new vessels at the disc have bled. So these are the 3 patients over the last 3 weeks that have presented. So these are treatment naive patients who have never had any treatment and presented with bleeding in both eyes. All 3 of them were under 50 years old. And so at the later stage, when all this blood congeals and the scar formation forms. So this patient had a ring of fibrosis, which in profile looks like that. The fibrosis is acting like a scaffold and pinching and pulling the retina away from the retina. So in these patients, they are at real risk of developing complete tractional retinal detachment with total loss of vision. So these patients without treatment will become light perception or no light perception of vision. Yeah. So in these cases, right? So this is probably one of the most challenging surgeries that we do, because after you clear the blood, you have to divide all these tiny little membranes without tearing the retina. So you can see there's blood underneath the membrane. In this case, I've stained the membrane with a steroid, so you can actually see the membranes, and you peeling them off and you cutting them off very meticulously, again without touching or tearing the retina underneath. And you can see the jelly is very sticky. It's almost like bubble gum.
It reminds me of, when you get a sunburn and your skin peels.
Yeah, it's not as crispy. So that's the thing. The jelly, right? It literally is very gooey, almost like so one of the thing that has really transformed surgery in the past 6-7 years for me has been the pre-operative injection of anti-VEGFs in these cases. So there is an effect. The anti-VEGF seems to shrink the blood vessels, so that's not so much bleeding. So for example, when you're peeling these membranes, there's actually stumps of little blood vessels underneath. So if you can shrink them beforehand, it makes the retina much less oozy and makes visualization much easier. And a secondary side effect is, I don't know why this happens, but injecting these anti-VEGFs before surgery turns this little bubble gum into more like, as you say, sunburned skin. It becomes a bit crispy. So it becomes easier to just pick it off, pick the little points. So it's little techniques like that have really transformed modern diabetic retinal surgery. So it makes it much less traumatic. I'm sorry, my video seems to have, oh no, it's gone, it's hung. This rarely happens, only once in a blue moon.
Yes, because it's a blue moon anyway.
I had to get that in. I had to mention that. I'm really sorry. I don't know how to. So let me just pause sharing and see if I can get it going again. Oh no,
This
the
picture
white
block
screen.
D is inside also.
Pardon?
This picture block D is inside the hospital. Yeah. That is block D, what? Isn't it?
All right. I can't actually see what's going on. My PowerPoint is my PowerPoint is restarting, so apologies for that. So okay, so okay, I'm sorry. Can you see my, okay, I'm going to share the screen again. Is that visible?
Yes.
Okay, I'm going to go to, sorry, let's just go all the way back down here. So yeah, so that's, so we've reached treatment of proliferative diabetic retinopathy. So this stage here, and these are, so this, if you like, is the nuclear option. So where you're trying to take that massive step and try and overtake the disease. And nevertheless, there's about a 20% failure rate, meaning that, despite surgery like that, patients still have very poor vision. So those patients with traction retinal detachments, especially very severe traction retinal detachments, sometimes, you have to counsel the patient that this is more a eyeball saving procedure. You're trying to reattach the retina so it doesn't completely detach, and that saves the eyeball in the long term. So it's a very sobering thought that despite all the advances, right, there's about a 20% failure rate when it comes to these patients with very severe traction retinal detachments. And sometimes you can spend 2-3 hours, meticulously delaminating all these membranes, and patients end up with navigational vision, meaning they can see to move around, but they still cannot read. Because at the end of the day, the disease process that led to this end stage was so severe that all function of the nerves have been lost. So my next topic is about screening, because as I mentioned, so I have this saying I always tout, screening is seeing. And really, in the old days, we used to examine a retina, look straight, look up to the right, and you shine this bright light into the eye. These days, we have these ultra wide field cameras, and Sunway is actually fortunate. We are fortunate enough that we have two ultra wide field cameras, one by Nikon and one by Zeiss. And these cameras, they can take these sort of photos, a wide field photo, meaning about 150 degrees, in under a second. And the advantage of that is you can manipulate you can zoom in, you can look at all these images, for an infinite amount of time, and the patient will not complain. Well, if you did it on a live patient with the slit lamp light, they would complain. And why do I say screening is seeing? Because, you can take this 1 second and you can detect and grade the retina disease according to that mild, moderate, severe vitreous hemorrhage. And, arguably these days you also have AI programs that can examine an image like that and make a determination as to what grade the retina is.
But then the screening, right, is only can be done if using this method by, let's say, ophthalmologists, right?
It doesn't have to be. So like in certain systems, like in the NHS, the screening, actually patients would come in my old unit anyway. What patients did was they would come in for an appointment, not to see the doctor, but just to have this photo taken.
I see.
And then you can train graders to examine the photographs and, grade the retina according to, the guidelines that have been present in place since 1985.
But for example, how about screening using a fundoscope? And I find like the fundoscope is the most difficult thing to use.
Correct. So we call it the guessing stick. And I'll show you why. Okay. So if you look at this image here, okay, this is your traditional 50 degrees fundoscopy camera. So your standard photo camera that you can get. And you get 50 degrees. So if you look at 50 degrees, right? If you look at this 50 degrees, you would grade it as normal, right? And then you would recommend 1 or 2 year review according to the ETDRS guidelines. But if you then look at an ultra wide field image, you see there are actually blood hemorrhages. So this patient is not normal. This patient has moderate diabetic retinopathy and should have 4 monthly reviews because they are about 5 times higher risk of vision loss over 5 years. So in ultra wide field studies, right, population studies, they have shown that about 33% of these lesions outside the 50 degrees are missed. And so these patients could be mislabeled as normal, whereas they will probably have moderate diabetic retinopathy. So if you imagine if you can miss this amount with a 50 degrees, a fundoscope only gives you about 5 degrees. So like if you look at the fundoscope through a dilated pupil, the magnification only allows you to see maybe the optic nerve and the vessels around it. So then you have to follow each individual. It's absolutely impossible. So that's why hence the name, the guessing stick.
I
So
see.
I have to be honest. The last time I used fundoscopy, fundoscope was I think in 2001.
That's even worse
Yeah,
than me.
correct. So I remember being asked to demonstrate it to some medical students, and I switched the light on, and it was facing the wrong way. So the light was shining directly into my eye. So I had a scotoma for about 3 minutes. So that's how bad, we tend not to use a fundoscope these days. So, when I was in Singapore, I actually conducted a little study, of ultra wide field grading versus the traditional fundus photography. And, we found that it was better, faster, and more effective. So we are really lucky in Sunway to have 2 ultra wide field cameras, and especially, and whenever I'm sent a diabetic, I always ask them do an ultra wide field camera photograph before, and I can actually examine the images. And 9 times out of 10, I've already formulated a plan of treatment. And so all the time that I do the consult is just to explain the disease to the patient, talk them through their options, and explain the risk versus benefits to the patients. So it really frees up chair time to do the things that are more important. And, these days, in fact, I think in 2 weeks' time, there's an AI company that's approaching us to talk about introducing AI into this screening. So in the future, you probably wouldn't need the graders. And our role would be to see the more serious diseases.
When do we start screening diabetic patients? Like
For type 2 diabetics, they're recommended to see the as a first off, as a baseline. They are recommended to see an ophthalmologist from the time of diagnosis.
Okay.
Yes.
The time of
And then
diagnosis.
the duration of follow-up depends on their severity. So for example, if there was no changes and the HbA1c was very well controlled, I would normally say, okay, I'll just book you a 1-year appointment, because our booking system gets confused if you go beyond 1 year. But I tell the patients, feel free to go up to 18 months in between. So 1 to 1.5 years. But for example, if the patient had moderate diabetic retinopathy, I would ask them for them to be seen every 4 to 6 months. If they had macular issues, I would ask them to review them every 2 months to do an OCT scan.
Does the use of statin reduce retinopathy?
Not statins per se, but there's a study that shows the Accord study, I believe. It shows that using sorry, it's a senile moment. I can't remember the drug, but it's said to reduce the amount of exudation. But statins, they're not known to reduce the retinopathy. No.
No. Huh?
No. Yeah. So the other thing is, here these are images, right? You see like this little image here, this is the fundus image, and you can, if you examine the patient, you probably would miss this on a slit lamp. Whereas if you use a digital image, you can enlarge it, you can play with the gamma and the exposure settings, and even apply filters. that will highlight the presence of new vessels. So, this is a patient with diagnosed as no diabetic retinopathy. So, whereas they actually have proliferative diabetic retinopathy. So these two cases really highlight the importance of ultra wide field imaging. Again, this patient's left eye was graded as no diabetic retinopathy, whereas it actually showed new vessels. So this patient actually went forward to having intravitreal anti-VEGF and laser treatment. So I think this is a compilation of all the slides, in our journey through blur vision. And yeah, we've reached the end. Thank you very much. I
Okay.
open the
There
floor
are-
to questions and
Okay, there's
discussions.
one by Dr. Nas. Is there any hope for patients via this treatment if they have been diagnosed with retinal detachment perhaps 5 years ago?
Again, I never say there's no hope. I always say it depends. So, for example, if you had a patient with retinal detachment just involving this sector here, not involving the center, it doesn't matter whether it's 5 or 10 years, you could say, okay, let's consider operating it if the detachment progresses. So I would admit, yes, 5 years of retinal detachment is a long time, but again, it also depends. If the vision is very poor, if the macula has been off for 5 years, I would say, yes, the chance of recovering vision is extremely low.
Another question by Dr. Susie from Docquity is, when diagnosing diabetic retinopathy, what are the key imaging modalities and diagnostic techniques that clinicians should be familiar with?
Clinicians, meaning ophthalmologists or general physicians?
I think maybe both.
Okay.
Ophthalmologists don't have to be worried about being familiar with their techniques, right? Only I think for let's say, health screening, doctors
Yeah,
in the peripheries, general
correct.
practitioners.
Yeah, I think the general practitioners, number one, I think a simple Snellen chart to look at the visual acuity. You need some
Really,
sort of objective measure of the patient's vision, because if there is a appreciable loss of vision, sometimes the patient may complain to you and they say, oh, my vision is blurred. And that's when you start investigating, you think through the causes. Is it a problem with the camera lens? Is it a problem with the camera film, but in a way, if the patient is diabetic, then really they need to be seen by an ophthalmologist. And the ophthalmologist, I would say, an essential tool to me, and this may be controversial, and maybe it comes from a position of being of privilege where you work in a center with an ultra wide field camera. So I place great stock in ultra wide field camera. I would say it's indispensable to me anyway, as an equipment. So really, I think as the cost of the ultra wide field cameras come down, I think it will become more accessible. To the general public, it's an awareness. So they need to be aware, and they need to understand screening really is seeing, because the majority of patients I see have reversible vision loss, and it is entirely preventable. So
when you say
yes,
entirely preventable, as in with better diabetic control or early detection?
both. So it has to be so at the end of the day, yeah, I have to acknowledge my endocrinology colleagues. I normally have a slide showing them, at Sunway, so they are indispensable, because I work very closely with the endocrinologists. I would call them up personally to say, hey, this person's retinopathy is deteriorating and progressing, can we, is there an issue with the diabetic control? For example, sometimes, if I see a lot of heart exudates, I will actually call them up and say, hey, can we consider, again, this is a senior moment, that drug that reduces the amount of, I mentioned in the Accord study, so these are the things that I need to work with. I would say it's essential as well.
Yeah, I think diabetic control, good diabetic control has been proven to reduce risk of retinopathy and even peripheral vascular disease and kidney failure. Not so much cardiac diseases, but I
Yes.
think the take-home message is always better control.
Correct.
Yes.
Yeah, and a lot of patients will ask me, say, oh, what's the point? I've lost my vision. I say, well, the point is that if you don't control it, it's going to make it more difficult for us to do anything for the eyes. It suddenly becomes, it's a vicious cycle. Yeah.
Okay, Dr. So is there a link between glaucoma and diabetic retinopathy, considering the common factor is diabetes?
Yes, diabetics are said to develop glaucoma more frequently. They are higher risk of developing glaucoma, but I'm not aware, to be honest, the direct link between the severity of glaucoma with the severity of retinopathy. But the two can coexist, and very often you need to treat it. But we always joke that very often the retinal surgeons are the one that cause glaucoma because, we're lasering, we are doing surgery in the eye, we are injecting stuff into the eye that raises eye pressure, so it's an eternal debate between not a debate, but I think it's synergistic. We work together, the glaucoma and retinal surgeons.
Okay, we need to wrap it up. Have a good holiday tomorrow. Tomorrow is Merdeka. And I just want to say 3 weeks ago, I was hit by a car, me, not my car, me, by a visually impaired driver. So if you are having impairment in your vision, please don't drive.
Yes, I hear you. I heard about that. I hope you're well. And I'm really traumatized to hear that it was one of our patients.
Yes,
because
in the
we
hospital
routinely,
car park.
Yeah, I mean, it's one thing, I routinely, and that's why it's not a joke that when I say, maybe that explains a lot about the Malaysian driving standards,
Oh my
because
God, it's
the number of people driving around with impaired vision, is actually quite shocking. So, well, good to see that you're well and have all limbs intact. Yes.
Okay, see you then. I went on
Thank
to
you.
run a 10 km trail run. Okay, bye.
That's fantastic. Despite the being hit by a car.
Okay.
Okay. Well done.
Okay,
Okay.
bye.
Take
Hey,
care.
thanks, huh?
No problem.
Good
No
trip to
problem.
Bangkok. Please don't put on
Yes.
weight. Watch your sugar level. Bye.
Yes. No red rubies.